objective be to comply with the ISO 15189-2022 requirement. So what is quality assurance in hematology laboratory? George, you do confirm if I'm okay and not breaking?
Yes, Mr. Francis, you are okay. Your sound is okay. So you can proceed.
Okay, thank you. So quality assurance in the hematology laboratory is intended to ensure reliable test results, as we have explained, with the necessary degree of precision. So precision is all about reproducibility. For example, if you do a test in a 20 runs, how close are those values? That's now the precision. The same analyte, let's say you are running, for example, a prothrombin time test. You are getting 10 seconds, then you repeat it 20 times. So you get 10.1, 10.2, 10. That's now a precise system. But imprecise system is where you are repeating the same analyte, the same condition, the same technologies, or rather you've given it a different environmental factors. And the first time you repeat, you get 11, the other time 12, the other time 10, the other time 9. That's now in precise system. And with that, you cannot rely on that particular system, because precision is a function of random errors. And then accuracy is how close is your result to the true reference value. So how close is your result to the target? If it is a QC that you are running, how close is this particular results you are getting to the target? And that's why you use LJ. So LJ will give you a distribution of your data around the target. And with that, you are able to monitor whether your system is deviating very far from the target, or your system is within check. Is it within 1 SD, 2 SD, 1 or 2 SD? And then from there, you are able to evaluate. So accuracy refers to the closeness of the estimated values to that considered to be true, while precision refers to the reproducibility of a result, but a test can be precise without being accurate. So I don't have that diagram of the dots, but if I know some of you might have come across it. So there is a test, your system could be as precise as possible, but not accurate. So which means there's a systematic error. So that deviation, the biasness, there's a systematic error that is giving you a bias. So maybe if you are reviewing your LJ, maybe you are seeing things like 10x, which means there's a persistent systematic error in your system. And that one, you would have to check your reagents and also have to check your calibration status if you are in chemistry setup. And the system can also be accurate and not precise. So if it is accurate and not precise, that simply means there could be a random error. So it would be sampling, it would be pipetting techniques, especially if you are not using the automated, and if you're using the automated platform, maybe the probes are not working well. So those are some of the things to check, and also the sample volume. Maybe you are giving it a small sample volume, and so therefore it's not, or even presence of a bubble. So that could be a random error. So you have to eliminate such kind of errors in your system. So types of quality assurance, we have got internal quality control and then external quality control. So in internal quality control, we refers to measures that are undertaken to ensure quality from the collection of specimen of the test up to the analytical results, and the measure should include the test results on control material. So this one now covers what you do at the laboratory to ensure that there is, the samples is of the right integrity. Remember, 70% of the clinical errors or other laboratory errors arise from pre-analytical phase. So you really have to put a lot of efforts at the pre-analytical phase to minimize errors as possible. So once you get the pre-analytical phase correctly, then you are unlikely to face much challenges in the lab. But that one doesn't mean that an error cannot occur at the analytical stage or at the post-analytical stage. Because still at the analytical stage, if your machine is not serviced, if your QC are not passing, your machine is having a systematic error, your machine is not well calibrated, still you will find problem at analytical stage. And also in post-analytical, rather you are giving wrong reference values, wrong interpretations, transcription error. So there's so many things that can happen, both in the analytical phase and the post-analytical phase. So now in internal quality control, you have to ensure that the pre-analytical procedures are well covered and you have got SOP outlining what is supposed to be done. And if it is sample collections, it is well defined in that they are able to know what kind of acutainers to use, when and where, and what orders they need to follow, and also even how to prepare your patient so that you are not getting wrong results. And then in the analytical stage, as we have explained, and also in the post-analytical stage. So for the external quality control, the assessment of results from produced at a certain site. So now you do your comparison with other peers. So peers means you are, let's say, in Nairobi region, and in Nairobi region, you have got like, let's not even talk Nairobi region, even Kenya or countrywide. So you can enroll in EQA programs. These ones will help you to achieve the external quality control. So external quality control is just to ensure reproducibility of those results. So which means that if your EQA are passing, your chances are very high that even if your patient repeats the same test, let's say in a setup like US or UK, they're likely to get the same result provided their quality check is okay as what you implemented in place. So it is meant to ensure that there is reproducibility in your system and that now there is no biasness. That if a patient comes to, let's say, in hospital A, they get their INR to be 4. Then they go to hospital B, the INR is reading 1. That is normal. So you see that discrepancy. So that's why you need to participate in external quality control so that if a patient goes to hospital A, whatever they get, if it is 4, it should be something close, maybe 3.9 in another hospital, or 3.8 in another hospital, or 4.1 another. So it should not change the clinical decision limit, which means that even if the doctors were to make any intervention, they will still do because it is still within the clinical decision limit. But a point where there's a discrepancy, a patient INR is reading 4 in lab A and then reading 1 in lab B, you have already changing the clinical decision limit, which means that the physician in lab A, in hospital A, will give medical intervention, but the physician in lab B or C, where the patient is having a normal INR, will not give any medical intervention. So you see that that's how it is important to have the example is just to highlight how it is important to have a proper quality system in place that will ensure that our results are as reproducible as possible. So what it does, it is essential in comparing lab performance with their peers, we have explained. And now, in this particular presentations, we are really going to focus much on the pre-analytical stage. And we are really going to cover several aspects of the pre-analytical stage in reference to coagulation testing. In the introduction, we were giving the general overview of quality assurance and what needs to be put in place for a lab to function properly in terms of quality. But now, Sasa, we are getting more specific to the coagulation testing. So under pre-analytical stage, the first thing is the request form. So the request form need to be properly filled. And in the first bullet, we are just talking about some of the information that you are likely to find in a request form. For example, the sex of the patient, the age, the family history, if necessary, the clinical marks, clinical remarks, like for example, whether these patients are on anticoagulants such as warfarin. So that one will really help you when you are interpreting your INR results, for example. You know very well that if they're in oral anticoagulants, the changes, the normal reflex changes for this particular patient is around 2 to 3, and it has to be kept within that therapeutic range. So if you have this particular history, it will really help you at the post-analytical stage. And also any clinical exam, if there is any, let's say you are doing a D-dimer test, for example, and maybe the patients have also done a Doppler ultrasound. So you see, if there is if you are finding the D-dimer in the lab and you want to correlate just your finding, then if in the request form it is clearly indicated that this particular patient have done the Doppler and you are in the same organization, you can check with the radiology team how the Doppler ultrasound look like. And maybe if it is still high, I mean, if they have seen clot in the Doppler ultrasound, then now you can do a proper correlation. So it means that your D-dimers that are getting very high at the lab is correlating with the findings of the radiology. And at that point, you don't need to keep on repeating or maybe interrogating your results further. So the request form is very key, and the clinical history of the patient is very key because it will guide the result interpretation and also troubleshooting at the lab, and also in case of any clinical exam that was done. So the next one is patient preparation, what you need to do to prepare your patients. One, the patient should be relaxed about 15 minutes because excessive stress and exercise will cause changes in blood clotting and fibrinolysis. So what happens is that if this patient, they are under stress, and you've just collected sample when they are still stressed. So at least let the patient come to the hospital, give them ample time, let them relax, and then take your sample. Because excessive stress are likely to have increased factor 8 and von Willebrand factors. And then patient on aspirin, if this patient is taking aspirin is antiplatelets drug, and so therefore prior to the test, they should stop at least 7 days. And if possible, the patient should be fasting to lipid levels. This one apply in this case that if you are using automated analyzers, like in your place, we are using automated analyzers for PT and INR. And this particular patient have got history of high triglyceride, or once you've spin their sample, you can clearly see that the sample is lipemic. So such patients, you advise them to take the test when they are on fasting status. It doesn't really interfere with what you are measuring per se, but what it causes is that the high lipid elements, that is the lipidemia, what it does, it will obstruct the optical. So it results into abnormal light scatter, and you are unlikely to get the right reading in automated analyzers. So after we have prepared our patients adequately, now we are in the specimen collection phase, where we want to look at the specimen quality control. So what are you looking at? What kind of specimen do you need for a coagulation testing? So one, you use the venous blood instead of the capillary blood. Capillary blood would require modification of techniques and locally established normal range. And as you know, capillary mostly is the one that you do through the fingerprint. So you can't use that method for coagulation. You also know that it may be very difficult getting the volume. Remember, for coagulation, you are using citrate and you have to fill the bottle almost full. That is, you have to observe the ratio 1:9, the ratio of the anticoagulant, the citrate to the blood. So proper collection, that is all blood samples must be collected by trained personnel. So in quality assurance, one of the things that you need to put in place is also the competency assessment program. So you have to ensure that the staffs that are taking this particular task are trained and they are qualified for this particular job, and not just trained regularly. The hospital, or rather the setup that you are working at, also has a competency assessment program, and this particular staff have also been certified to be competent, and this one can be done annually depending on how you've programmed your system. And then the next one, all blood samples must be collected by trained personnel. That one we've said. So you're supposed to clean the site of the vein puncture and then select a proper vein, and then you follow the order of the draw. So order of the draw, if you are using, if the same patient is also having a culture, then you'll start with the culture. And then the second one would be a coagulation, a bottle, that is the citrate, the blue top. And then after blue top, you do the plain, then heparin, then EDTA, and finally you finish with the gray. So that one is just important to ensure that you are not contaminating these other bottles with what? With the anticoagulant material. For example, if you collect heparin before citrate, and then you could end up having heparin contaminating the citrate. You will get very high high APTT results because heparin will inhibit thrombin, so it will never clot. So you can you can see how you will be giving very wrong result for that particular patient. So it is very important to observe them. It is very important to observe the order of draw. So you are supposed to apply tourniquet not for more than 1 minute, and because if you apply it longer than 1 minute, it may result into venous occlusion, which result into hemo concentration, leading to increased fibrinolytic activity, platelet release, and activation of cofactors. So when you are doing a coagulation testing, once you've located your vein and you found the right vein that you want to take your samples from, you minimize leaving the tourniquet for too long. It should not be there for more than 1 minute. And we have said that somebody is saying the volume is low. Hope they're able to get me. So what we are saying that when we're applying the tourniquet, don't leave it for more than one. Ideally, once you've located the vein and you found the right vein, you're supposed to release the tourniquet as you once you are in and the blood is coming out. So release the tourniquet, because when you do it for long, you will result into what? You will cause hemoconcentration. And we have said venous occlusion resulting into hemoconcentration, and that will cause fibrinolytic activity, platelet release, and activation of cofactors. Another thing that you need to take you need to take note of is a disposable plastic syringe, and the recommended gauge for coagulation testing is 19 to 22 for adult, 23 to 25 for kids. And this one is to avoid contact activation and hemolysis. So when you are doing coagulation and the patient has got that, I know sometimes it might be difficult to keep this, especially where the patients have got very small veins and might be forced to use the smaller gauges. But in cases where you are able to use the right gauge, so what you do, which means, and most of the patients in the population love good veins. So always use gauge 21. Gauge 19 is a bit big, but you can use gauge 21. I know the green one. You can use gauge 21 for coagulation samples. That one is very key, and it will help in avoiding contact activation, as we have said, and also hemolysis. So avoid collecting blood from indwelling catheters. For those ones who are working in hospital setups with ICU or HDU, and you've been sent to withdraw a sample from a patient who is in ICU and they are on catheters. Kindly avoid those sites for coagulation, because most of those sites are rather heparinized, the tubing that they are using. So chances of you collecting blood that is already contaminated with heparin is very high, and that will really mislead will really give you very false elevated coagulation results. That is especially in APTT testing. So you also have to ensure that there is proper filling of blue top tube, as we have said. You must ensure that the ratio it is ratio of 1 of the anticoagulant to 9 part of blood, and then mix it thoroughly. That is 5 to 6 times, gentle inversion. That's how you are supposed to mix your sample. So the anticoagulant that is used, one is trisodium citrate. That is the anticoagulant of choice because calcium ion is neutralized more rapidly in citrate. That's why we are using citrate. Another reason is because it prevents continued tissue plasminogen activator to binding to plasminogen activator 1. So it also blocks that particular binding. So at least it also arrests the coagulation pathway for that. And then the labile factors are unstable in oxalate, and that's why you cannot use the oxalate tubes with the oxalate as anticoagulants. So labile factors are like factor 5 and factor 8. Heparin and the DTA directly inhibit the coagulation and interfere with endpoint determination. So you can't use a sample that has been collected in heparin tube and also in the DTA for coagulation. And APTT tests are very sensitive to the presence of what? Of heparin. And then the recommended volume is 9 volume of blood to 1 volume of anticoagulant, as we have discussed. And one thing that is very important is right labeling. That is, you have to perform proper patient identification. So this one is important both at the bedside where you are collecting your sample, or maybe at the phlebotomy room where you are doing your sampling collection. You must ensure that the patients are correctly identified, and always allow the patients to introduce themselves. Don't ask them like, are you John or Nyango? Don't do that. Allow the patient to state their name clearly and then confirm with the materials that you have, one being the request form. Confirm whether those details in the request form are correctly matching that of the patient. And within the laboratory to avoid mistakes. So also within the lab, you don't have the patient there to confirm with, but ensure that at all points you are processing the right sample. So always observe the labeling. So ensure that the patients have been, the sample has been labeled correctly and properly identified. And again, when you are doing your analysis, ensure you maintain the identification throughout the system. So sample transportation, the sample should be delivered as quick as possible to prevent deterioration of the labile factors. And then certain investigations will need to put the sample in crash ice for urgent fibrinolytic test. So if it is a test for like those ones for fibrinolysis.
Excuse me, Mr. Francis.
Yes.
There's one of the officers, the members, medical laboratory officer, who is requesting if you could just stress, on the order of acutaneous.
Oh, order of draw.
The order of draw.
So order of draw. I wish I would have.
I don't know if you can go to the slide that it was being shown.
It is under sample collection level because I didn't put the match details there, but
okay,
this is the order.
Okay, all right. You can just pardon on it and then proceed.
Yeah. So on the order of draw, number one, we said if the patient is having culture, you start with culture. So, and then the second one, the second one is blue top for citrate. And then you do plain tube, then you do heparin, the green top. And then, so for plain top, you can either have red top or the yellow one. So that is the sequence after the coagulation. And then now heparin, next the green top. And then after heparin, you do DTA. And the final in the list is a gray top for fluoride, sodium fluoride. So we said that you avoid interchanging. For example, why you cannot collect heparin before coagulation. We say that if you collect heparin before coagulation and it contaminates the citrate tube, that is the blue top, you are likely to have, you will have inhibition of coagulation, and so therefore your APTT results will be very prolonged. And we've also seen in the presentation, DTA also does the same thing. So you cannot interchange. Even if this patient is having TBC and let's say PTINR, you will start with you will collect first whether you are using vacutainer system or the syringe system. If you're using vacutainer system, you will still go in first with the blue top and then you do EDTA. If you are using the syringe, once you've taken the blood, you will fill them in that order. You start filling the blue top for the citrate and then you move to the EDTA. So depending on the number of tests that the patient is having, but remember not to interchange. For example, why can't you not collect EDTA before heparin? Because EDTA EDTA has got potassium, and if this sample is going to be used for chemistry, we will get a very highly elevated potassium. So that's why you should collect heparin first before EDTA. So another reason is that EDTA also chelates what? Chelates calcium ions. And so therefore, if you collect DTA before heparin, you're likely to get very low values of what? Very false low values of calcium. So just consider always look at the order, because every order has got a reason. The reason why you start with the blood culture, because you should get this, the site should be sterile as possible, and then you start with the what? With the blood culture. And again, when you are filling the blood culture, if you are having both aerobic and anaerobic tube, blood culture bottle, you start with which one? You start with the aerobic, and then you move to the anaerobic. Reason being, if you are using syringe, that air that is in the syringe, you will spell it out fast in the anaerobic bottle before you dispense your sample into the anaerobic. So it is always good, because every step there's a reason as to why we are doing. So the reason why you cannot again collect plain top before the blue top is because they have got clot activators. And so therefore, if you contaminate the clot activator by accident, contaminate the blue top, then again, you will have a sample that has clotted. And so therefore, we'll be giving you a very wrong results for the coagulation test. So that is the chronological of order of draw and some of the logic behind. So the key thing, don't cram, just know what comes after and the reason as to why you are not supposed to do that, so that it guides you. Depending on the test panel that the patients have, you will be able to follow correctly. I hope that one is clear, George.
Yeah, that's clear. Thank you. You can proceed.
So the next one, we are going to look at the specimen storage. For example, the old blood for prothrombin time test is stable at room temperature for 18 to 24 hours. And then for a PTT, all blood is stable for 6 to 8 hours at 18 to 25. So you are in maybe you are not doing the test there. So the best thing is to separate if you're not doing the test at the point of collection. But again, if it is not, maybe your reference lab is not very far from you, then you can still use the old blood. For prothrombin time test, it is stable for 24 hours at room temperature. But for a PTT, remember, prothrombin time test could be stable because of what are we looking at there? It is the extrinsic pathway. So in the extrinsic pathway, we have got factor 7. And factor 7, those are the prothrombin group of factors. So in the prothrombin group of factors, we have got factor 7, factor 9, factor 10, and factor 11. So they are relatively stable, but they are also vitamin K dependent. And then we have got fibrinogen group of factors, where we have got factor 1, factor 5, and factor 8. So factor 5 and factor 8, these ones are in the, especially factor 8, this is in the intrinsic pathway, and that's now the APTT. So factor 5 and factor 8 are the labile factors, and they are only stable for 6 to 8 hours. And for those ones who are working in the blood bank, they now understand better as to why when you collect a whole blood and you are supposed to, from a donor, you're supposed to make component out of it. You're supposed to use fresh whole blood that is less than 6 to 8 hours old. Reason being, you want to preserve the labile factors, because after 6 to 8 hours, they start to deteriorate, or rather reduce in levels. So that's why for APTT, it cannot be stable at room temperature for so long. So it is only stable at room temperature for 6 to 8 hours. And then for heparin monitoring by APTT, whole blood are stable at 18 to 25. That is for the at room temperature for 1 hour, and after 1 hour, there is a full decrease of APTT due to heparin neutralization by platelet factor 4. So there are those patients who are on heparin therapy. Maybe they have got clot in their system or DVT, and the management or the doctors are using is heparin. So such patients are normally closely monitored for APTT, I think 6 hours apart. And so that one you will have to monitor. The good thing is that most of this is not something that can be done at home. Most of these patients are admitted, they are at the hospital, and you monitor their APTT very closely, so you can collect the sample and meet that target of 1 hour. within that is required for APTT testing in this particular group of patients. So the analysis of plasma samples after centrifugation needs to be completed within 4 hours of collection. So the ideal that is recommended at least 4 hours of collection. At that particular time, your labile factors are still very active. And then samples for platelet function should be kept at room temperature and should not be transported via pneumatic system, ensuring sample agitation is kept at minimum. So for those ones who are working in labs with total lab automation. Remember that I don't know whether we have such a lab in Kenya, but I know that those labs with the pneumatic system where they don't have porters to take the samples, as in they don't use porters to transport the sample to the various sections. So what they do is that once the sample has been collected from the bedside, it is a fully automated system. You just place the sample in that pneumatic system, and then it goes directly to the lab. And the machine will pick it, separate the ones that goes to hematology, to chemistry, and to various lab, and even does the centrifugation automatically, and even give you the plasma. It is seamless system. It even reads and know which is supposed to be done where, and load in the right machine. So if you are in that particular system and we are doing a platelet function test, maybe it could be the quantitative or qualitative test, you avoid. So that agitation, that movement of samples. So to avoid that, you in that case, for those particular samples, you will exempt. They have to be delivered physically to the lab and not via the pneumatic system. So for the specimen storage, the specimen that cannot be processed within the designated time should be centrifuged and the platelet poor plasma frozen at -8. So let's say you are doing a research in that particular area, or maybe you are doing a validation study and you need these samples to be used later. So what you do, you will collect those particular samples and ensure that the plasma that you're having is platelet poor. So which means you will centrifuge your plasma, and you will centrifuge your sample, take out the plasma carefully without disturbing the Buffy coat, and then centrifuge again, and ensure. And after centrifuging again, remove the plasma and then store that one. You can store it at -80, and it can stay for. It will keep your labile factors and all other coagulation factors intact for a very long time, even for 1 year. So frozen specimens should be transported on ice to maintain the sample integrity. And storage of frozen specimen is allowed at -20 for 2 weeks. So all frozen specimens should be thawed at 37 degrees Celsius water bath within the 10 minutes and properly mixed prior to analysis on hemostasis analyzers. So when that time comes that now you want to use your sample that you had frozen for this particular coagulation studies, you will thaw them at 37 and then mix properly and use it for analysis. So here we are going to look at the sample processing. Where the sample processing in hemostasis, laboratories should have a validated procedure to yield platelet poor plasma with a platelet count of less than 10,000. So we are talking about the platelet poor plasma here. We mean that your samples, if you run it on your TBC machine, the platelets that you are getting should be less than 10,000. So you should use a proper centrifugation procedure that you, as a lab, you've validated, which means you've done it and you've tested it and you've confirmed that the plasma that you are yielding is platelet poor and having a platelet count of less than 10,000. So the centrifuge should be maintained at room temperature, that is 18 to 25. And all samples should be double centrifuge. So as we have said earlier, so you double centrifuge to remove the residual platelets that may affect hemostasis and yield platelet poor plasma prior to of freezing. So before you freeze these particular samples, you do a double centrifugation. And double centrifugation will mean the first step is to centrifuge the situated blood and carefully remove the plasma. And carefully here we mean that you remove the plasma without disturbing the Buffy coat. Because if you remember, once you've centrifuged the plasma, even the ones that use in the lab, there's that Buffy coat. And Buffy coat is where we have got the platelets and the WBC settling at. So if you disturb it, chances are you will suspend back the platelets that you've already separated. So you carefully remove this situated plasma without disturbing or rather interfering with the Buffy coat. And then second step is to centrifuge the situated plasma. Now you centrifuge whatever you removed now separated, you centrifuge spin again to obtain your platelet poor plasma. And then you can validate by running and see how what amount of platelets does it give after this particular procedure. If it is less than 10,000, then that procedure is successful and you can maintain that. Then you freeze your sample at -80. If at all you will need it for a longer storage, but if it is just a shorter storage, you can freeze at -20. So if more than one tube is collected, don't pull the plasma together. So let's say you've collected more than one citrate tubes. You pull them, you pull your plasma separately. Do not pull them together. So, and microfilters should not be used to remove platelets. And this one, so again, just for you to achieve this platelet poor plasma requirement, just use the centrifugation without using the microfilters. So reason being, if you use microfilters to remove the platelets, this can lead to loss of factor 5, factor 8, factor 9, factor 12, and even the Goldwyn-Brandt factor. And remember these factors you need in your coagulation testing, both APTT and what? And INR, which is affecting amine and prothrombin time test, because these are factor 9, factor 8, these factors are in where? Factor 5 is in the common pathway, and 8, 9, and 12, those ones are in what? Are in the intrinsic pathway. So you can see it will affect both testing. So those are some of the things that you need to take into account when you are working in a coagulation setup. So after talking about the pre-analytical stage, which we said have a much of the errors, and that's why we've spent a lot of time. At least you've seen how you are supposed to do your sample storage. You've seen how you are supposed to process those particular samples, and even the hours, the stability of this particular sample. So some of the things that you need to do, and even the anticoagulant tube that you're supposed to use. And the key thing is to also observe the order of draw and why you are doing that. So in the analytic stage, depending on your setup, we have got setup where they are not using automated analyzers, and now they are using the manual method. So the manual method, you will need a water bath. So if you are using a water bath, you have to ensure that this water bath is maintained, properly calibrated, and is reading at 37. So calibration is just to ensure that the temperature you are getting from the water bath is the right temperature. It's not that the water bath, the actual temperature is 40, but what the water bath is giving you is 25. So that now is a malfunctioning water bath because it is not maintaining the temperature correctly. So you need to ensure that that one is achieved at 37. And then refrigerators and freezers, so temperatures to be at 4 plus or minus 2 for refrigerators. But for freezers, you maintain at -20 plus or minus 2, especially where you are going to store, when you are going to store your situated plasma for later use. And then plastic tube for sample dilutions. Don't use the glass tubes, because glass tube has got that contact activation. So again, that one might interfere with your findings. So what you need to do, especially if it is APTT, so what you need to do when you are separating samples, use a plastic tube, and storage and reagent preparation. So we prefer plastic tube. But now when you are doing the actual testing, like the ones who are using now the manual method, we use glass tube for clotting tests. So pipette, so again, another thing, you will need pipetting because we have to separate samples. We have to measure the volume that is required when we are doing the test. So a range of graduated glass and automatic pipette, we should be accurate and durable. So just ensure that your pipette are also calibrated and they have got that stickers up to date. Just to ensure that whatever you are pipetting, if it is 200 microliters, the pipette is as accurate as possible and not giving you a dead volume instead. So again, if you are in a setup where you are doing manual, you will need stopwatches and clocks. So if this is the case, again, these stopwatches need to be calibrated and they also need to be as accurate as possible. Because remember, that's what you will use to time. For those ones who have done, I know nowadays there's a lot of automated analyzers, but those of us, some of us would be privileged to have done the manual coagulation testing. That's the moment you place the reagent and then you swirl within within the water bath at 37 as you time. So that's what I mean. It means that your stopwatches has to be as accurate as possible so that your timing, if it is 10 minutes, then it is giving you the right time. So for automated coagulation analyzers, it is important to ensure that their temperature control and the mechanism for detecting the endpoint are functioning properly. So if you are using the analyzers, automated platforms, you have to ensure that the ppm for these machines have been done and your machines are in check, which means in terms of temperature, it is not faulty. It's able to maintain the required temperature for reaction of 37. And at the same time, the mechanism for detecting the endpoint of reaction is functioning properly so that you are able to get an accurate result and not a false reaction. So the next thing we look at in analytical stage is now focus on the reagent. So on the reagent quality, the focus in the quality control procedures for ensuring satisfactory for performing routine coagulation testing. So again, your reagent, there has to be of quality to ensure that your PT, APTT, fibrinogen, or even the thrombin time test is correct. So thromboplastin reagent for PT derived from bovine and rabbit brain or lung. So again, for the thromboplastin reagent, that's why they have the ISI. So depending on the manufacturer, so they can either derive their thromboplastin from bovine, it could be from a rabbit brain or lung, or even from human placenta, something of that sort. So again, that's why they have that ISI, so that you once you get your PT reagent, you are able to configure the ISI in your machine. And if you are doing manual, then you will use the right ISI to calculate the INR. And then the PTT reagent contain two types of activators. So some of them will contain particulate activator, that is kaolin or silica. Some will contain a soluble activator containing ellagic acid. So you just need to read the insert of your reagent and follow the instruction as per the manufacturer, and also store it in the right temperature that the manufacturer has recommended. And for the PT, as we have said, it's very important. Don't ever forget, once you've received that reagent, you check the ISI that has been given by the manufacturer and configure that in your system for correct result interpretation. So the test results will depend on the specific reagents and instrument used. So reagent selection, purpose of the test will guide you. The instrument compatibility will guide you. For example, which instrument are you using at your place? Then the reagent cost, maybe reproducibility and reagent sensitivity. Then sources of errors in coagulation could be from open vials or reagents, which means you've let your reagents open and they are prone to contamination. Improper storage, you are not following the manufacturer instruction for those particular reagents. So you were supposed to check the bottle. Those reagent vials, they always have the storage temperature indicated on them. So excessive exposure of reagent to either heat or cold, then deterioration of reagent by freezing and thawing. So if it is not recommended, just follow what the insert says. And then reconstitution. And for those ones which are lyophilized, are you using the right amount of of distilled water to reconstitute this particular reagent. If it is written 2 ml, you use 2. If it is 1 ml, you use 1. So that's what it means, so that you don't end up over diluting or under diluting your reagent when you are preparing. And of course, expiries, we need to check the expiry of those particular reagents. So calibration is also very key in analytic stage. And calibration here will mean that use unknown quantities of analysis to adjust the analytical system to ensure that the result will be accurate. Actually, in a proper control system, your QC are just to check the calibration point. And that's why, if especially those ones who are working in the clinical chemistry setup, you'll interact more with the LJs, and the LJs, once there's a shift or a trend, you will know that your calibration curve is not that good, and you may need to have to recalibrate, because from the QC you can tell how the trend and the shifts are. So this could be based on the national standards, commercial standard, or normal pool plasma, and that's what you need to use. The principle of calibration is repetition to minimize possible errors at each stage of calibration. So you normally see the calibration point. We have got some are 2 endpoints. So it is repetition, and it look at the factors that is generated at each and every point. Then from there, now you'll use your QC system to check the calibration curve, whether it is functioning properly. And by doing that, you are maintaining the accuracy of the system. So types of quality control material you could use commercially, you could use platelet poor plasma, and this one, which means you are doing a comparison. It is an alternative method if at all you cannot afford the commercially prepared one, which means you are using a previous sample, but you stored it and you've known then the concentration of this particular sample. Then you run just to check if there's that reproducibility of that result. And then duplicate test on patient specimen, as we have said, using the control plasma to detect precision, and batch must include control. So at least in your control, you should have normal and abnormal, so that you are covering the analytical measuring range for that particular analyte. And of course, the standard operating procedures should be in place for every coagulation test that you are doing to guide. The standard operating procedures is meant to guide the personnel in a way that even the new staff, when they come, they are able to follow the SOP correctly and to end up with the same result as the experienced one. So that's the purpose of SOP in lab. And then now in the post-analytical stage, the accurate recording of results is very key. Accurate recording of results and interpretation. So you minimize typographical errors as much as possible, so that you don't end up giving the wrong report. So review here is very key, especially where you are using manual system. You have to key these results manually. At least you can have a second eye or a second person check or counter check whether the results that have been reported are the true measurement that were obtained in the coagulation machine. Then the next one is speed reporting. So you need to write the normal values in the results. So the report should indicate the reference ranges, just to guide the clinicians. And then biological validation of results. Biological validation simply means that the reference ranges that you are using reflect your population. And then conservation of specimen, as we have said, if you are told you are going to use, again, you need to have a policy in your setup for how long are you going to store these particular samples. And of course, you know what to guide you when you need to repeat an analyte. It means, like for coagulation, the stability has got a very short window, so you may need to have a fresh sample collected. Then proper waste disposal, because we are dealing with biological waste in this case. So that you need to have a policy on proper waste disposal in place. And then again, transfer the report to the doctor or the ward. So how you are the endpoint user, the clinicians or the physicians. If it is automated system, they could be receiving them in their email. If it is manual, then you need to have a way on how you communicate the same to your doctors. If it is a HIMS, then at least they will interact with the system and see the results once once they are posted. And of course, documentation. For quality, you document every single step that you've done, because if it is not documented, it is never done. So that one was post-analytical stage. So some of the common errors could be in the collection stage. That is faulty collection of the sample, underfilling or overfilling of the bottle. So you need to observe the ratio, it is 1:9, and unsuitable anticoagulants. Do not use heparin or EDTA for coagulation. Collection of blood through a line that has at some stage been in contact with heparin, as we've said, avoid the indwelling catheters. If it is coagulation, just remove from the vein direct or rather arterial. Contamination of the cowling, the contact factors, undue delay in sample analysis, which means you collected your sample at 8 a.m. It is for APTT and you are running it at 6 p.m. You will not get the right value, because the right correct results being that your labile factors would have deteriorated. Use of inaccurate pipettes. Your pipettes are not calibrated, and so therefore they are not giving you the right volume. So even with the testing, we are not really giving the right quantity of sample that it's needed to perform those particular steps. And then machine malfunctioning. Maybe you are not, the machine has broken down, so you need to do the necessary requirement, like contacting the provider or rather the vendor to come and repair the machines. And once that one is done, again, you do your QC check just to ensure that the machine is functioning properly after repair. Incorrect water bath temperature. The water bath has been there lying there for maybe 5 years, 4 years. Nobody has ever cared to even contact the service providers to come and calibrate. And we are all happy that the water bath is at 37, when in real sense, the temperature there is at 24 or even 25. So you are not giving the right temperature for reaction. Again, it means you are violating all the results that you are getting in manual setup, where you are using the manual. So just ensure that the water bath is at the right temperature, or rather you've not set the water bath in the right temperature. You are doing a coagulation test, the water bath is at 40, and you are not adjusting that. So calcium chloride at incorrect concentration or not freshly prepared for the APTT. So thanks for your time. Having seen what we need, some of the highlights to maintain a quality system in quality assurance. For the analytical stage and the post-analytical, it cut across the lab. The only gray areas of the differences comes in the sample preparation. At least today we have seen that our patients for coagulation testing need to have some rest, at least 15 minutes, and then they don't need to be in undue stress. And we've seen how stress can lead to elevation of factors like factor 8 and even red blood factor. So those are some of the take-home messages. The stability. And we have seen, like, for example, PT will be stable. Maybe something that I didn't mention on the prothrombin time test, avoid freezing or putting the prothrombin time test in the freezer, because there is that call in the freezer or in the fridge. It is reasonably stable at room temperature for 24 hours. So try to analyze your sample. And we've said the ideal time for coagulation is 4 hours, right from the time of collection. So try to analyze your sample as soon as possible. And if you are sending to another lab, then you need to separate. But for the PT, kindly keep it at room temperature, if at all it will be received within those 24 hours. Because if you put it in the fridge or in the freezer, there is that called activation of factor 7. And again, that one will give you false results for the PT. Now, George, back to you.
Thank you very much, Mr. Francis. I think you've actually done your best, and that is reflected from the comments from members here. You can see Dominic Wambua is actually appreciating your presentation, Charity, among others. So at this point, I'd also like to appreciate those who have managed to follow with us, being from the beginning up to this point. Thank you, Francis, who joined from Nairobi, Purity from Mombasa, and also Charity Mendo from Mombasa, and everyone who is present and was managed. Now, at this point, would like to welcome questions, any reactions from the attendees, the medical laboratory practitioners. If maybe you'd like to be given a chance to talk, if you'd like to speak, kindly just raise your hand. There's an icon there that is indicated raise hand. If you click it, I'll be able to see it from my hand and give you the chance to speak. You can just speak, say like a comment, or if you have a question, you can just also speak it out. I think you have that chance. In the same manner, you can also use the chat box to text your question so that it can be read out to the presenter for response. In the meantime, I can see quite a number are reacting with claps, with love, and likes. I think that's quite commendable and it's very encouraging from your end. So far, I cannot see a question here, but okay, one question has come up from John. Let me just read it the way it is. He's saying, apart from aspirin tabs, what other medical tabs okay, I think Mr. John Wahome is asking about the medications that interfere with prothrombin time test. One of the most outstanding ones is aspirin tabs. So, Mr. Francis, would you elaborate on some medications that interfere with prothrombin time test? Over to you.
Aspirin would not really interfere with the prothrombin times per se. We say it is an antiplatelet drug. And in setup where you are now doing the platelet testing, for example, qualitative or rather, especially qualitative, because now you'll be looking at the functioning, whether the numbers are normal, but again, the patient is still bleeding, and which means that their platelet is not functioning optimally, and so therefore they are not able to form that primary platelet plug. So in such cases, there is normally the qualitative test for platelets, just to ensure that the platelets are functioning normally. So things like ADP, yes, such kind of tests are normally done. So in such case, if the patient is on aspirin, they have to stop for at least 7 days, because aspirin is a cyclooxygenase inhibitor. And if the patient will take the test when they are still on aspirin, then it means that the defect that you will be seeing, it will be difficult to tell whether it is actually from the platelet of the patient or as a result of the effect of the drug they are on. So on a prothrombin time test, we said the clinical history will guide clearly, because if this patient are on warfarin, mostly the anticoagulants, the oral anticoagulants, are the ones that are likely to affect the prothrombin time test, and that's why they are used to. If a patient is on warfarin, they use INR, or rather prothrombin time test, to monitor. This is because, and you can see the therapeutic range is high. It is 2 to 3, unlike the normal INR is up to 1. So if we don't have this history that this patient is on either warfarin or any other oral anticoagulant, you might be struggling interpreting this particular report, or rather we might miss. We might treat this patient as having an issue, and we will go to other tests like the mixing study to check whether there is a factor deficiency, you see, and the doctors will even try to following up other tests when clearly this particular patient is on warfarin, and that's if the INR is 2.5, for example, it's very okay for that patient. They don't need to adjust. They don't need to adjust the dosage. So they will always adjust the dosage depending, because if it is very high, then the doctor has to lower the dosage of the oral anticoagulant that the patient is getting. Let's say, for example, patient A is having the INR at 4.5 or even at 3.5. This particular patients need review and dosage adjustment. If it is very low, again, because if it is very high, it will predispose them to thrombosis. Again, if it is very low, it will predispose them to bleeding. And so therefore, in that case, the doctor needs to again increase the dosage. Let's say it is 1. So 1, you see, it is normal for the population. And if you don't have this history, we might assume that this patient is actually normal and doesn't require the medical intervention, when actually they need medical intervention, and their warfarin or oral anticoagulant dosage need to be adjusted so that they are within the therapeutic range for this particular patient. So again, things like, let's say the patient is in drugs like rivaroxaban, that is heparin, and it is a factor 10 inhibitor, things like that. And that is likely to interfere with both PT and APTT. So the clinical history, the kind of drug the patient in, is very key in coagulation testing. As you can see, depending on what that drug does, it might affect either PT or APTT. So now that I've mentioned that, I have seen a question on mixing studies, and I want to go step by step. So for the mixing studies, I will start with a normal patient who have presented to a lab or to an hospital. And some of the tests that has been requested, the coagulation testing, both PT and APTT. That is the prothrombin time test and the activated partial thromboplastin time test. Remember, the PT will check for the for the extrinsic pathway. The key players there are tissue thromboplastin, and which is factor 3 and factor 7. And of course, you know the coagulation pathway. And then now we have got APTT looking into the the intrinsic pathway. So let me go first to the extrinsic pathway. So if a test is done and this patient is having high PT, then they could be suffering from factor 7 deficiency, or they could be on anticoagulant drugs, just as we have said. Yes. And then, so in that case, the APTT is normal, but what is elevated is what? Is PT. So that is straightforward. That is factor 7 deficiency. The follow-up test there for the clinician is factor 7 assay. So they need to confirm whether the factor is functioning normally. That is if these patients are not in any anticoagulant drugs. Let me go back to the intrinsic pathway. So on the intrinsic pathway, you've done this test and it is elevated. So if it is elevated, it could be, remember the PT is normal. So if it is elevated, it could be the patient is suffering from factor 8 deficiencies. It could be an hemophilic patient, either hemophilia A or hemophilia B. Hemophilia B, the Christmas disease, factor 9 deficiency. Hemophilia A, factor 8 deficiency. So in that case, again, the doctors can follow the follow-up task could be factor assays, the factors that are in the intrinsic pathway. Now come patient C. Patient C has got highly elevated both APTT and PT. So in this case, it is unclear whether there is because the problem is in the common pathway, and the problem could also not to be in the common pathway. It could be the patient is having hypofibrinogenemia or dysfibrinogenemia. The fibrinogens are in normal counts, but not functioning properly, or they have got a very low count of fibrinogen levels. That is in the common pathway. So again, it is affecting both. But it's also good to rule out, having that in mind, it is also good to rule out the presence of inhibitor, that natural inhibitors. It could be lupus, anticoagulant in the system of this particular patient. It could be antithrombin 3. So again, you have to think in that particular setup. Now, that is how the mixing study comes in. So when you meet such a patient where both PT and hepatic T are highly elevated, you have to rule out presence of natural inhibitor stroke factor deficiency. So how are you going to do this? You do a mixing study. In a mixing study, what you do is that you take the abnormal patient, the patient that is having the abnormal result, 50 micro, it is has to be ratio of 1 to 1. I'm going to use 50 in this case, 50 microliter of their plasma, and then mix with that of the normal plasma. So the normal plasma, I mean that within that you can even pull. Within the setup in the lab, we have got several patients who had done coagulation testing not long ago, PT, APTT, and they are both PT and APTT were normal. These are normal population. They should not be on drug or whatever, or on treatment. That is in management of coagulation disorders. So once you've taken the normal plasma, 50 microliter of it and 50 microliter of the abnormal one. So the normal one is supposed to supplement the missing factors in the deficient one. I hope you are getting that point. So that's how the mixing study comes in. You mix 1 part of the normal plasma and 1 part of the abnormal plasma. And then you repeat the testing. So you repeat both, you repeat the testing on the mixed plasma, the new sample that you have now, where you've mixed the normal and the abnormal. So you repeat both the PTT and the PT. Now check if it has corrected. Check whether that one has corrected your APTT or PT. So if there is a correction, which means whatever you have is giving you a normal result, then it is a factor deficiency. So if it is a factor deficiency, then you will have to follow up with factor assays to establish which one. Or you can still do other studies if you are in a resource poor setting where you cannot do the factor assay. You can still do something that resembles mixing studies. But now in this case, you'll be using a stored plasma. So if you use a stored plasma and it has correct, then you know the problem is in extrinsic pathway. So that would be a factor 7. If you've used a stored plasma and it has not correct, then the problem is in the intrinsic pathway. The labile factors are missing in the stored plasma. So with the stored plasma, it will not correct.
Yeah, I think Mr. Francis, you've actually elaborated it so well. Maybe you can give a summarizing and then summarizing statement and then proceed to more questions. You can proceed.
Thank you so much. So I wanted to the point on the mixing study to come out clear. So where there is no correction at all, then there is a presence of the natural inhibitor. And that's now where you will see the doctor now requesting tests like now protein C, protein S, antithrombin, 3 tests, and the lupus anticoagulant testing. So that one I hope I've answered that question on mixed studies. So if there's any other question so that we talk about it.
Okay, good. There's another question here about the timing. I'll ask you 2 questions in one. There's one question here that is asking about the right time. Is there a timing element when you want to collect the blood sample for coagulation studies? If yes, then what time is the best? Another one is about collecting sample from a baby whose veins are very difficult to locate. So how can one obtain the samples from such a baby? Samples for coagulation tests. Over to you.
So for the babies, we said you use the small needles. You can use gauge 23. It's recommended for the pediatrics. And you said for the adult, you use the gauge 21 for the for the adult. So for the babies, if they've got very difficult veins to locate, you can use a butterfly. It's allowed. Butterfly, I think, is gauge 23, if I'm not wrong. Or you can even use a smaller one, gauge 25. The other one was timing on. Timing for coagulation studies, as we have said, it will depend. Like, for example, the cases where we have highlighted for lipemia, that's where we said if you are maybe you are doing coagulation testing and you've seen in your plasma that you are getting highly lipemic. So in such cases, because we said the lipid will interfere with the optical reading of automated analyzers. So if you are using automated analyzers, you advise the patient to take the test in the morning hours when they have fasted. And there's another thing. So another thing on timing, we said again, you also have to assess if this patient is on due stress, you give them time to relax. Because again, we've said if they're on stress, that one will likely to interfere with the labile. I mean, will increase false increase on factor 8 and von Willebrand factor. Any other question? There's something.
Good. Thank you very much for that. There's another question here from Kenneth Kiplagat. Kenneth is appreciating your presentation, and the question attached to it is: does tranexamic acid medication affect INR? Tranexamic acid is a component of the drug that is taken for reducing bleeding. For example, ladies that are menstruating take it to reduce the bleeding. So the question that Kenneth is asking, does such a drug, the tranexamic acid, does it affect INR? Over to you.
INR is affected by vitamin K dependent drugs. So, if at all tranexamic acid is vitamin K dependent, then it will automatically affect the INR. So things like warfarin, and almost oral anticoagulants affect the same.
Okay, thank you very much for that. Quite a number of attendees are appreciating your presentation. Joy Mutiso, Frida Mugo, David Cheriot, Aurelia Kahindi, they are appreciating your presentation. There's one more question. This question is from Moses. Moses is appreciating and saying thank you for the very insightful presentation. And the question is, in post-analytical stage, what did you mean by biological validation of results? In post-analytical stage, what did you mean by biological validation of results? Mr.
Biological
Francis.
validation, am I still audible? Biological validation will mean that the reference ranges that you've given in your report represent the normal population that you are serving. So some people would go by option of adopting what is in the kit insert, but that is not what the standard dictates. If you read, for example, ISO 15189/2022, it requires biological validation of these normal reference ranges, which means you need to do a study within your population and find out what is the normal INR, for example, for thrombin time test or APTT in this particular population. Let's say in Nairobi, what is the normal APTT like? What is the normal PT like in this particular population? Remember, these kits, most of them are manufactured outside the country. So the population that they used to come up with that reference ranges is very different from the one we are serving here. So that's why it's good to do that biological reference range validation for our setup. Next
Thank
question.
you very much. That's great. Um, yes, as I said, many of our members are appreciating your work. John Maina, Philip Kipiego Perry, Sheila Calvins, Kevin Wamosha, Michael Bernard. Thank you very much for your feedback, colleagues. This is encouraging, and it's wonderful to just hear from you appreciating this presentation. Thank you very much, Simon Ongoro. That's quite commendable. So we are moving towards the end of today's presentation, and I would like to appreciate everyone for taking part in this um, session. And at this point, I would like to give our presenter a 1 minute just to give us a parting shot, and then we shall conclude this session. So, Mr. Francis, if you're there, you can just give us a parting shot, a 30-second or 1 minute parting shot as we conclude this session. So, this is your moment again. Over to you, Francis.
Okay, thank you, George. I would love to thank everyone for having participated through today's webinar. And the take-home message, the quality assurance is applies the same, irrespective of which part of the land we are applying. It's only that now, looking at the nature of tests in coagulation, there's some specific rules, or rather things that we need to take care of. Like, for example, the kind of bacteria you are using, it's quite different from what you use from other tests. See, like chemistry, you can use plain top to do so many tests under one tube, which is not possible for coagulation. So the key thing that I would say is um, let's know the reason as to why we are doing that. Because if you understand the reason behind every single step that you do in a quality system, you will find it very easy to implement, and you'll find it very easy to comply. So as the highlighted in the presentation, the pre-analytical stage, I've got so much work compared to these other stages. Actually, in the analytical stage and the post-analytical stage, it's cut across the same, but much of the difference is in the pre-analytical stage. So let's be in the lookout, especially on the order of draw. Maybe there are people who have not known and they have been collecting DTA before citrate, or even collecting citrate classes. So if you are doing that, then you need to stop. And somebody can say, maybe I've never found any problem with that, but at some point you could have given a wrong result without knowing. So it's always good to follow the procedure. Again, look at your inserts and store your reagents according to the manufacturer's prescribed insert. If it is a manual, follow the instruction that have been given. If it is automated system, ensure that your machines are working properly and they are maintained. Your QC system is in place and it is working properly. If it is a machine that has got LJ, ensure that you've used your LJ to monitor your trend and shift so that you are able to detect deviation in your system. At post-analytical, if it is not automated, ensure there is counter-checking by a second person just to ensure that we are not giving a wrong result even after having the right reading from the machine. So thank you, everyone. And let's always, and remember to document everything. In quality, if you don't document, it was never done and you can never go back. So traceability is very key in quality. Competency assessment is very key. At least it doesn't mean that you don't trust your staff, but at least it just shows that they are able and they are able to follow the procedures and the SOP that are in place. Those SOP are not cast on stone. In case of anything that arises in the system which need an adjustment, you can always review your SOP to accommodate. Thank you, everyone.
Thank you very much, Mr. Francis, for an educative and thought-provoking presentation. Uh, on behalf of LMSK, we really appreciate your presence here and your time just to enrich the medical laboratory fraternity with evidence-based knowledge. I think that's quite commendable. To our attendees, the members who just found it good to learn with us, we really appreciate your presence and your dedication. We are dedicated as well to ensure that you are well acquainted with the knowledge, and also your points are also um, um, well uploaded so that you find it easier when you'll be now renewing your license. Now, just some quick announcements for the webinars. Ensure that you put correct details. Ensure you double check, especially your registration number and the ID number, as well as email address. After this, we will communicate to you via your email addresses. So ensure that you check your inbox and also maybe your spam or junk folders for our emails. When you receive any of our emails, just tap and read. If it reads that your points have been successfully uploaded, then they have indeed been uploaded. And if maybe there was some error that we requested you to assist us, kindly do that promptly so that we don't lose time. There's no more time, and so we are dedicated to ensure that you don't lose any point just by the fact that time has elapsed. So take that into consideration. We are still on course. Um, Michael Bernard, you are talking about yesterday's webinar was cancelled. No, that is on the database, but your points are well in your accounts and your certificates are also okay. So don't worry about that, the notification that you got. So that's just to clear our database, but on your um, portals, both the CPD portals and also your emails, you have the points as well as the certificates. So don't worry about that. Just rest assured that by the end of this year, um, all of you, those who are dedicated to our sessions, will have achieved at least 50 CPD points to renew their licenses. So if you find any challenges are always there. Ensure that you reach out to any of our WhatsApp admins so that you are promptly assisted. Do not wait up to the last minute. Just keep checking from your end, and if you find anything that maybe you'd like to get more information about, just reach out and then we will assist adequately. Um, Thank you very much, everyone. At this point, the time is up. It is 4:30, and we come to a close of this session. We really appreciate you for taking part in this session, and to this far, on behalf of LMSK, we wish you a happy and a wonderful evening. Thank you very much.